The last part of the neuro lecture is going to talk about Guillain-Barre, which is actually a type of neurological disorder, which is an autoimmune demyelinization of the peripheral nervous system. It results in progressive destruction of the myelin sheath around a nerve, and it slows or blocks nerve impulses from node to node within the nervous system. Typically has a very acute onset and can lead to varying degrees of motor weakness and paralysis within the body. Typically, these patients will be patients that have ascending motor paralysis. 90% of clients will fully recover after this incident, but unfortunately 10% are left with residual disabilities. The latest thoughts is that it's a viral trigger where the immune system destroys the myelin sheath that surrounds the nerve axons, the root ganglia, and the spinal nerve, and this destruction then slows and blocks the leaping of nerve impulses from node to node. So the patients will be healthy patients that all of a sudden start to develop this ascending paralysis. Like I said, it's possibly due to a virus trigger. 2/3 of all patients that have Guillain-Barre will have the development of symptoms following some sort of a viral infection, such as a cold or things like that. Also has been found to follow trauma, surgery, certain immunizations, such as the group A strep, rabies, those types of things. And also back in the late 70s, there was a swine flu vaccination, which there was a large outbreak of Guillain-Barre after this particular vaccination was given. And it was linked to a bacteria that was actually found in the eggs and poultry industry because eggs was a compound of making up that vaccination. It was helped to make the serum. So typically the patients will have this viral illness 1 to 3 weeks before the onset of these neurological symptoms. And patients, when they have lab tests done, they'll note that they have a T and B lymphocyte defect problem going on. It happens to about 1 to 2 people for every 100,000 people. It affects men and women equally. Typical ages are between 15 and 36 and also between 50 and 75. And although the symptoms can take days or weeks to advance, it can lead to full paralysis in some patients. And the mortality rate is anywhere from 4 to 15%. And this is due to the autonomic instability that these patients have. Types of GB include, based on the pathophysiology, like we said, ascending paralysis is the most common type of Guillain-Barre that is seen, where the patient has weakness and numbness that develop in the legs, and then this progresses upward. This can lead to paralysis of the respiratory muscles. 50% of all patients will develop this respiratory involvement problems, and 20% of all patients that develop Guillain-Barre will need to be put on a ventilator for respiratory support. What typically happens is, as these patients start to heal and get better, their muscle strength and functioning returns in a descending order. There are 3 phases of Guillain-Barre. The acute phase typically lasts between 1 to 3 weeks. It's where the patient ends when there's no more physical deterioration. The plateau phase is after this, and that occurs within 2 to 3 weeks after the initial onset. And this can last anywhere from a few days to a few weeks. And the recovery period can last anywhere from 6 months to over 2 years, and that's where there's actually remyelinization of those nerves taking place. So remember that unfortunately 10% of patients may have this paralysis that becomes a permanent thing. It just depends on how that patient's body just affects or is affected by the Guillain-Barre syndrome. The symptoms that the patients have will be symmetrical muscle weakness and sensation loss. The patients will complain of severe pain to numbness and paresthesias in the extremities. It may progress to the point where the patient also has facial weakness. As we said, many patients will develop the respiratory symptoms due to paralysis of the intercostal and diaphragmatic muscles. Patients, due to the problems that they have with paralysis, will have orthostatic hypotension, cardiac issues, tachycardia. They may develop paralytic ileus and urinary problems. They may have loss of bowel and bladder control and lose deep tendon reflexes due to this. It's diagnosed by clinical symptoms, the fact that the patient typically has had a recent viral illness, and it will also be noted that the patient will have elevated protein levels in cerebrospinal fluid, and EMG studies will show decreased nerve conduction. Medications for this particular disease are more to just treat the symptoms. Patients may be put on morphine or anticoagulants due to the immobility issues. Due to hypotension, they may be put on vasopressors to help with blood pressure issues. If they get super infections due to immobility, they may need antibiotics for that. And the thing that's very challenging for this particular patient's care is that cerebral functioning is not affected at all. So patients will have normal pupil function, normal level of consciousness. They will just have body paralysis and, as we said, perhaps respiratory paralysis. And the thing that's so difficult is patients will not know if they're going to fall into the 90% category of patients that make a full recovery, or if they're going to fall into the 10% category of patients that are going to have permanent disabilities as a result of Guillain-Barre. Our case study is a 26-year-old woman who's admitted with Guillain-Barre. Upon assessment, it's noted the patient has developed weakness, numbness, and tingling in her feet that has now progressed up to her body, and she does give a history of upper respiratory infection approximately 2 weeks ago. So some good nursing diagnosis for patients with Guillain-Barre will be ineffective airway clearance, so frequent respiratory assessments, monitoring ABGs and SaO2 values are going to be important. And if that patient does develop respiratory depression and failure, then the patient needs to be intubated and put on a ventilator. With our particular scenario, we're going to say that our patient did develop respiratory failure and was transferred to ICU. And as you remember, anywhere from 10 to 30% of patients will end up on a ventilator that have Guillain-Barre. Another treatment method for these patients is plasmapheresis, where patients will have exchange of plasma with a special machine. We talked about that earlier in the neuro lectures. This actually removes the circulating antibodies that are responsible for the symptoms that the patient has. And typically this is most beneficial within the first 2 weeks after the onset of the symptoms. So patients will typically receive 3 to 5 treatments, 1 to 2 days apart over about a 10-day period of time. So if needed, a second round of plasmapheresis can be used for these patients. And interventions are listed there. Patients need to be weighed before and after treatments. The shunt needs to be taken care of with aseptic techniques so they don't get infections at the shunt site. And another option for patients is to receive IV immunoglobulins, IVIG, and this has been shown to be as effective as plasmapheresis. It's a little bit safer to give and immediately available, so many physicians are now opting to treat their patients with Guillain-Barre with IVIG. It does have side effects similar to when you're hanging a blood product, so you need to look for fever, chills, and anaphylactic reactions, meningitis, those types of things. Complications of patients with Guillain-Barre due to immobility can include thrombophlebitis, muscle atrophy, contractures, infections, stress ulcers, skin breakdown, depression, and then, like we said, 10% of patients will have permanent disabilities. So to prevent complications, especially with respiratory issues, make sure the patient's head of the bed is elevated. Have emergency equipment at the bedside for those patients that may develop respiratory paralysis. Sometimes Guillain-Barre, they'll have paralysis that stops at the abdominal level area and they never develop the respiratory complications. But in case the patient might develop that, make sure that you have an ambu and trach and intubation equipment readily available for those patients. Preventing infection is going to be important for those patients that are hospitalized with Guillain-Barre, particularly if they're back in an ICU setting on a vent. So use sterile technique with suctioning and make sure that you're watching for signs and symptoms of not only respiratory infections but also urinary tract infections. Impaired physical mobility, things to help with that would be turning those patients Q2 hours, getting them out of bed when they're able, putting them in high-top tennis shoes and splints to prevent foot drop, and allowing for independence. There was a video that I saw when I was in graduate school of a patient that had Guillain-Barre, and actually the video, when they interviewed the patient, she was actually a patient that 2 years after her initial symptoms, she was still wheelchair bound, but she did regain respiratory function. But she pretty much told her story on this video, and it was very interesting because she said when she was back in the ICU and she was on a vent, the only thing that she had any control over are where her pillows were placed. So she said she was very particular on that and just being turned and things like that because she felt she'd lost control over everything else and all her body movements and motor control, and that seemed to be the only thing she had any control over. So she said she was a challenging patient to the nurses because she was demanding on that because she felt it was the only thing that she could possibly control in her life at that point. Nutritionally, patients, while they're on a vent or having respiratory difficulties, may have to receive feeding tubes, enteral feedings, total nutritional therapy, monitoring eyes and nose, daily weights are going to be important. And then once that patient, if they start to reverse symptoms and swallowing returns, remember they'll probably need swallow studies done before they're started with food. Bowel and bladder elimination are also issues. We've talked about that. So giving good Foley care and getting the patients in a bowel problem is going to be important. And then giving them lots of support for the psychological issues that would go along with this disease. As we talked about earlier, they feel very powerless, very anxious about what their outcome is going to be. Will they make a full recovery or not? And so trying to get them into support groups and getting them communication systems while they're on a vent is very important. If the patient asks, will I be the one to make a full recovery? It's just a matter of a waiting game. The patient just needs to give lots of positive reinforcement. The paralysis does reverse itself, and just give lots of family and patient support. The NCLEX question for Guillain-Barre is that the nurse is admitting a client with GBS to the nursing unit. The client is noted to have ascending paralysis to the waist. So knowing the complications of this disorder, which items are the most important for the nurse to bring into the patient's room. And although all of those things would be good things to have at the bedside, the one that's probably most important and addresses the issue of impending respiratory failure and cardiac problems would be number 3, which is the EKG and pulse oximetry. And this concludes the neuro lecture.